All right. We will go ahead and get started. Thanks again for everyone who is on the webinar today with us. We are excited to have a conversation today about curbing prescription drug costs in Colorado. This is our Data to Drive Decisions webinar series that we do typically on a monthly basis, and we kind of alternate the topics and what we're talking about. So today is all about prescription drugs and what Colorado is doing in terms of trying to lower costs. So we'll talk a little bit about prescription drug costs in Colorado, give you kind of some overview of the data that we are seeing in the Colorado All-Payer Claims database. Then I'm going to turn it over to my colleagues in the Prescription Drug Affordability Board to get an overview of what they are doing. And then we'll also review the Division of Insurance PDAB dashboard, which is very robust and exciting. We'll have time for questions and answers, and just a little housekeeping on the Q&A. You are all muted at this point in time. Questions can be submitted through the chat feature. It says Q&A, but I think you're only going to see that chat feature. Please feel free to submit chat questions at any point in time. We will have an official Q&A section at the end. So depending on the question, we may interrupt presenters and have them answer the questions, or we may hold them to the end. We are recording this, and all the recording and the slides, everything that you're going to see today will be available on our website under About Civic News and Events and the event resources. I'm very excited to be joined today by two colleagues from the Division of Insurance. Lila Cummings is the DOI Prescription Drug Affordability Director, and then Kate Davidson is the DOI Manager of Data Science. I am Carrie Frank. I'm the Civic Vice President of Communication and Marketing, and my team is responsible for all the public data, including the drug rebate data, which we'll show you today. In case you're new to Civic, our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data to improve health and healthcare. And if we reach that goal, our vision is that everyone has the opportunity to be healthy and has the same ability to have equitable, affordable, high-quality healthcare. We are a nonprofit organization, pride ourselves on being independent and objective and focused on service. So we serve a variety of what we call change agents, which are individuals, communities, or organizations who are boots on the ground trying to improve healthcare and make Coloradans healthier. So we work with clinicians, hospitals, employer groups, government agencies, state agencies, nonprofits, health plans, researchers, you name it, anyone who's touching healthcare, all with the focus being the consumer in the center of everything we do. So one of the ways we serve is that we are the administrator of the Colorado All-Payer Claims database. We call it the CO APCD for short. We turn that data into both public data and non-public data, which we'll talk about a little bit of both today. We also have research and evaluation services that we can provide. We do a lot of community engagement, and then we have focus areas in advanced care planning and palliative care. So the APCD has over 1 billion claims. It goes back, we actually have claims from 2009, but most robust from 2012 on. Between 2013 and 2022, we had a billion claims, over a billion claims. We reached that mark. Very excited about that. It represents over 70% of the medically covered lives, but we do have pharmacy, dental claims in there as well. That represents 5.5 million unique lives in Colorado. We get information from a number of 48 commercial payers plus Medicaid and Medicare, fee-for-service and Advantage. What's not in the APCD are federal programs like the VA, TRICARE, and Indian Health Services. They aren't able to submit to us right now, although we might become the very first state to get the VA claims, and that's kind of in progress. We've been working with them for a while. We do not get uninsured and self-pay claims, and then the majority of ERISA-based self-insured employers, they can voluntarily submit to us, but we can't mandate that they submit to us because they're under different federal regulations. So we get also, in addition to monthly claims, which I'll talk about, we get annual prescription drug files. We get payers submit an annual file for drug rebates that talks about the total prescription drug costs that they have every year. total rebates that they've received, and then the spending and rebates by drug category, generic, specialty, and brand. And then we also started collecting recently specific files for the Prescription Drug Affordability Board, which includes the 15 drugs that cause the greatest increase in payers' premiums, the 15 drugs that the payer paid for most frequently and for which the payer received a rebate from manufacturers, and that the payer received the highest rebates as determined by percentage of the price of the prescription drug, and the 15 drugs that the payer received the largest rebates for. So those are annual files. We also recently started collecting annual value-based contract pharmaceutical files. So those are value-based contracts that are medically administered drugs and drugs dispensed from a pharmacy. We get just general basic info for the drugs, like the name and the NDC that is under a value-based pharmaceutical contract, the number of people on each drug, and the number of people that have a measured outcome. Because it's not just about, when you're talking value-based contracts, you want to think about what is the outcome and are we getting the value for that drug. We also are getting total spend for drugs under the value-based contracts and for drugs with measured outcomes. So the outcomes that can be measured include, and the payers indicate which type of outcomes are being measured. So whether it's reduced hospitalization, reduced relapse rate, qualifying event, discontinuation, if it's a disease prevalence outcome, or other, and then they specify to us what other type of outcomes are being measured. So those are annual files. Those are outside of the monthly claim submission that we get, those drug rebate and PDAB files. And then we also collect prescription drug information on a monthly basis, just through the normal APCD monthly process. So we collect general information about all drugs that have been dispensed, the drug name and the national drug code. We have information about the fill date and the day's supply, whether it's a generic or a brand, they indicate on the claim, if it's a compound drug, and then whether it is a refill or not. We get all the information about how much was paid by the payer and by the patient and in total. And then we get the pharmacy information. We have the patient's information and then the prescribing provider information. And those are collected again on a monthly basis. So that's very timely data that's not in the annual files. So what do we see out of all this information? That's the exciting part. The impact of prescription drugs on healthcare spending. So in 2020, Medicare is off. So we have information for 2021, but not including Medicare fee-for-service because they're behind in submitting their pharmacy claims to us. But we did see in 2020 across all of the payers, including Medicare fee-for-service, $5.4 billion in spending, or nearly 20% of total healthcare spending was specific to prescription drugs. A lot of money. And we see that in the database, if you look across all healthcare services that are getting paid for, prescription drug spending is rising the fastest. So across all payers per person per year in 2020, across all payments, spending is about $7,200 per person per year for services. That has increased from 2013 to 2020, 27% across all types of payments. But when we break it down between provider payments, outpatient payments, pharmacy payments, and hospital payments, you can see that the pharmacy payments is really the biggest jump that we've seen across time. Even though it's not necessarily the biggest spend, provider payments are higher, which we would want to see for, primary care and things like that. Pharmacy has jumped quite a lot. And you can see all of this information and look at it in more detail in our community dashboard on our website. So drug rebates, we'll kind of dive a little bit into this piece just because we'll be talking about, what the PDAB is doing, and drug rebates is part of what they're looking at and part of what legislation has changed lately to make sure that these rebates are starting to come back to the employers and to patients. So this is a very complicated graphic. I won't go through the whole thing, but basically drug rebates are coming from the drug manufacturer and going to pharmacy benefit managers that then can give some of those rebates. They can either keep some, or they can pass through the entire amount or portions of the amount to the health plan as a means to get the drug on the formulary with the health plan. And part of the reason that drug rebates, I think, proponents of it are that it could potentially lower healthcare costs because you're getting a rebate back from the drug manufacturer. However, it's not necessarily going directly to the patient or consumer. We'll talk about that later. For Medicaid, it does, but for Medicare and for commercial payers, opponents of drug rebates say that they actually might be increasing drug costs overall. So when we get the data from payers, the drug rebate information includes the total rebates, compensation, remuneration, and any other concessions. So I just wanted to make sure that you knew it goes a little bit beyond drug rebates in the data that we receive. So I wanted to show you guys, before we get too deep into this, where you could go look on our website for more drug rebate information if that is something of interest to you. This is our affordability dashboard. It's under public data, focus areas, and affordability dashboard. You just click on it, and the affordability dashboard includes prescription drug rebates. So you click on prescription drug rebates here, and you have definitions and methodology up at the top, but you're able to look at this information in any way that you might want to. So if you want to look by payer, if you want to look by year, the way that we get our annual files for drug rebates is it goes back 3 years historic information. So we always will collect 3 years historic every time we do it. So next year we'll collect 2020, 2021, 2022. And then you can break it down also by drug type. So if you want to just look at generic, brand, specialty, or brand and specialty combined, you get some output of total spending and rebates. You have some trend information. There's also volume of drugs, so number of drugs that are being prescribed versus the percent of spending. And then detailed information about the generic, or you can do other filters. So there's lots of stuff in there. I'm not going to spend a ton of time on that. I'll hop back over here to our presentation and show you a little bit more what we're seeing in the data. I don't know why it went away from my slides there. Hold on just a second. I lost my mouse completely. Where did it go? Technology is a beautiful thing, isn't it? Sometimes when it works. I don't know what happened. Apologies. Oh, there's my mouse. I got it back. Yay. All right, here we are. So what are we seeing with drug rebates? So overall, across all payers, what we're seeing is that drug spending is increasing. So again, I think the potential benefit that drug rebates could have is that it lowers overall costs. But what we're seeing is prices are rising with and without drug rebates. So roughly 25% increase in drug spending across all payers, and rebates have increased for roughly 25%. So it's not really bringing total costs down. When we isolate just to commercial payers, we're seeing total drug spending, again, rising up to $2.3 billion. This is the total spend. This blue part is the rebate amount. So we're seeing rebates are going up as well. And that percent of total spending is the green bar. That is the percent rebate of total spending. So we're seeing everything is still increasing. If you look at just commercial payers, they're receiving more and more rebates. The percentage of the actual dollar amount increased 106% from 2019 to 2020. When you isolate just to specialty drugs, and this is a concern for rebates too. Specialty drugs only represent 1% of the actual total volume of drugs, but it actually represents 44% of the total spending for drugs. So, not very many getting prescribed, but a lot of cost going towards specialty drugs. And when you break it down in terms of the spending for specialty and brand, again, we're seeing a lot of increase in the total rebates that are coming back. This is the percent rebate of total spending over time. Brand is the orange bars. So we're seeing that rise from 24% in 2019 to up to 29% of total spending is coming back in rebates. And similarly, the rebates are rising for specialty. And if you look at just specialty drugs and brand drugs alone, increases in total drug rebates has gone up 84% for specialty drugs, 125% for brand drugs, and the total spending has gone up for both specialty drugs and brand drugs as well. So there is a potential that these rebates are actually encouraging higher use of specialty and brand drugs. So what's happening with those drug rebates? Again, there hasn't been a lot of transparency around that, but beginning in January of 2024, per the legislation that passed, Senate Bill 1330, payers or PBMs must report to DOI that they are actually using those rebates to reduce costs. And for small group and large employer plans, they have to be making sure that those rebates are being used to reduce employer or individual employee costs. And for individual plans, the rebates need to be used to reduce premiums and out-of-pocket costs for prescription drugs, and that their insurers are maximizing the use of rebates to reduce consumer costs. So that's a good thing. ERISA-based self-insured employers, similar to we can't mandate that they submit data to the APCD. It's an opt-in process. So self-insured employers need to ask their TPAs and ASOs that they want to be a part of this too, and will receive those drug rebates back. So that was a lot of information about drug rebates and prescription drugs. And I think the exciting part is what the PDAB is doing to actually lower prescription drugs. So I'm going to turn it over to Lila now to let you guys know more about what they are doing. So welcome, Lila. Go for it.
Thanks so much, Gary. And that's fascinating. And I'm here today. I'm just going to give an overview of the Prescription Drug Affordability Board, or PDAB's work, but then quickly turn it over to Kate Davidson to talk about some of the pretty amazing work that she and the division have done to use data to provide for the board, to assist the board in their decision making. So we can go to the next slide. Thank you. So at the highest level, the PDAB was created in 2021, along with another entity, the Prescription Drug Affordability Advisory Council. And it was Senate Bill 21175 that really was the enacting legislation that guides this work. So the PDAB, or the board, is a 5-member board with rulemaking authority. And the 5 members of the board have experience or expertise in clinical medicine or healthcare economics. And I will note that on the board, we've got 5 really just incredibly dedicated and talented members. We have 2 physicians, 2 pharmacists, and a hospital administrator that really represent both the geographic diversity of the state as well as kind of the political diversity of the state. And this board meets every 6 weeks, and they are kind of 2 years in, they're well into their work. There's also a 15-person advisory council, and this advisory council is made up of experts and individuals both along the kind of care continuum chain. So, we've got patients, we've got family members, we have folks representing individuals with chronic conditions, and then also providers and prescribers represented on on the advisory council. And then there's also folks along the supply chain. So there is a brand name manufacturer representative, a generic manufacturer representative, wholesaler representative, pharmacy benefit management firm, and carrier representatives, as well as representatives for unions and employers on the advisory council. So really a very strong advisory council with expertise kind of across the care continuum, as well as the prescription drug supply chain, really giving advice to the board as the board's work unfolds. Okay, so the advisor or the board itself has a number of responsibilities outlined in statute. So they have a responsibility to collect and evaluate data on the cost of prescription drugs for Colorado consumers, a responsibility to perform affordability reviews when a drug meets certain triggers outlined in statute. As the board, and we'll talk a little bit on the next slide of the different steps that are involved in affordability reviews. And if the board determines that there's evidence that a prescription drug is unaffordable for Coloradans, they may then exercise one of their other duties, which is to set an upper payment limit, or UPL, on drugs that the board has deemed unaffordable. There's a maximum of 12 for the first 3 years of the program. I will note that this past legislative session, that was actually expanded to a maximum of 18 in the first 3 years. But I'll also note that the board, in this inaugural year of affordability reviews, is only examining 5 drugs. So we're not quite sure we'll hit this coming year that limit of 18. The board also may make policy recommendations to the General Assembly. This is something that, particularly as the work this year has unfolded, I think there's a lot of interest amongst board members and advisory council members on, what do affordability reviews and what is the data that's being presented, what does it uncover, and are there different tools outside of the board's kind of current responsibilities that might make sense to recommend to the General Assembly as a tool to address prescription drug affordability. And then beginning last summer, there is an annual report due to the Governor and General Assembly about drug prices, board activity, and impacts to providers and pharmacies. I will say the report this past July was relatively light since the board had not conducted any affordability reviews yet. We anticipate that this report will be more robust this coming year since the work has started. Okay, so I'll go box by box on this slide and really outline at the highest level, this is kind of where the board's work lies. And I'll talk a little bit about the process and then what's happened this summer. So for context, the 5 members of the board were appointed by the governor in September of 2021, and they really spent the first 18 months learning how to be a board, right? Learning how to be a rulemaking body. They hosted a number of learning series, of which CIVHC was one of the presenters, to better understand how to use data to drive decisions. So they hosted a number of learning series, and then they got to rulemaking. So a considerable amount of time was spent by the board promulgating 5 rules that guide the work of their program. There was a general provisions rule, a rule on an appeals process, a rule on affordability reviews, one on upper payment limits, and then also a rule regarding carrier requirements to report use of savings. So if and when the board sets an upper payment limit, carriers have a responsibility to annually report how they used savings from upper payment limits to reduce the cost of prescription drugs for Coloradans. So they spent quite a bit of time promulgating those rules, talking with stakeholders, talking with experts, and then also promulgating or adopting a number of policy documents with those rules as well. And so they spent the first 18 months really getting their program set up. And then at the beginning, the end of this past spring, they started doing the work. So at the top row, you'll see the board's main duties in the affordability review space. So the first is to identify which drugs are eligible for an affordability review. And Kate is going to spend some time talking about kind of how this was calculated and how CIVHC data really helped in this space. There were 604 drugs that were eligible according to statutory criteria to be considered for an affordability review. That list of prescription drugs was released on June 9th, I believe, of the 604 drugs. The next step that the board needed to consider was selecting drugs for an affordability review. There were a number of broad categories that the board needed to use as directed in statute to make the selection. So how do you go from 604 drugs to a smaller number of drugs to actually conduct a full affordability review, that next step? And what ended up kind of occurring was there were 17 discrete data points that the board needed to use. Most of those data points came from databases. So it came from the FDA's website, came from civic data. And if you do the quick back of the napkin math on 604 drugs times 17 data points, that's over 10,000 data points the board needed to consider. And so Kate's going to walk through her just pretty incredible dashboard that really takes how do you take that much information and synthesize it and present it in a way that allows for kind of actionable decision making by the board. And so on August 4th, the board used this dashboard, used the underlying data, and then selected 5 prescription drugs for affordability reviews. And so that's the stage the board is currently in. You know, it's actively happening right now, where they're doing a deeper dive for these 5 prescription drugs into conducting affordability reviews. And I will note that that really dives deeper than what a database can tell you. So at this stage of the process, there are a lot of conversations with patients and caregivers, with providers, with researchers, with folks with scientific and medical knowledge, as well as reviews of the literature on the effectiveness of these prescription drugs and the comparative effectiveness of the prescription drugs. There's also a dive into whether the prescription drug has an orphan drug status designation. What are access concerns that are being identified by patients and providers? And so we're actively in that stage. So I don't think Kate's going to comment too much on that today because it's unfolding right now. But as this information unfolds and as the board's work continues over the next several months, information will be brought before the board for them to make a determination on whether they believe there's evidence that the drug is unaffordable for Coloradans. So then if and when the board determines that a drug is unaffordable, they could then choose to establish an upper payment limit, or UPL, that would be established through rulemaking, so through a more kind of formalized rulemaking process. There's a responsibility to notify consumers of the decision to establish an upper payment limit, inquire whether manufacturers intend to make the drug available in Colorado. Then after rulemaking concludes, an upper payment limit effective date would begin. And then after that time, payment for a specified drug would not exceed the upper payment limit. So again, not an exhaustive process map, but at the highest level, that's kind of what the board is working on. That's its process and where it is today. So with that, I will stop talking and turn it over to Kate.
Thank you. That process is, the whole, what everything in PDAB is going to do. And the data that we're going to focus on today is really that identification and selection. So I'll dig into that and then share the dashboard. So it starts with the eligibility. That is pretty prescriptive in statute, how a drug can be eligible for the board to review. And it is for folks or for drugs with a WAC per course of treatment of over $30,000. That's for brand name and biologic products. For biosimilars, it is if the biosimilar is not at least 15% less than its biologic counterpart. And then for generic drugs, there has to have been a 200% increase in the previous 12 months, as well as over, I think, $100 per course of treatment. So the APCD data was essential in that course of treatment piece in particular for the eligibility, because we really had to figure out what is the average course of treatment for folks in Colorado taking this drug. And that might seem quite easy for some drugs, like a pill that you take every day. That's generally going to be 365, or, maybe a little lower because people don't always start their medicine on January 1st of the year and take it every day. But then with other drugs, particularly if they depend on the size of the person for the milligrams or the topical treatment, that gets really tricky. So we ultimately used kind of the average utilization, removing outliers to determine that course of treatment. And then we look at the list price, the WAC of the drug, to determine if it does meet that $30,000 threshold. So we came to the eligible list. And then, as Lila mentioned, the board had to kind of figure out how they were going to select drugs with those 17 data elements. So they went through a prioritization exercise, and it was a group exercise to essentially determine, of those 17 metrics, what are the 5 most important to the board this year in helping to determine which drugs to select and which drugs have, you know, a greater impact on Coloradans, and then a UPL might have a greater impact on if it were to be set. So they did that exercise. And then with that exercise, we created a prioritized list of drugs to then present to the board and let them review all of those 17 data elements for all of the drugs in a couple of different ways so that they could really get into that decision. So I will share my screen now and we can go into the dashboard just so that I can show the exciting data stuff. All right, so I'll kind of quickly go through this, but it is a ton of information. And as Lila said, you know, it's over 10,000 data points. It's hard to really synthesize that in an easy way. So the first, oh, I'm apparently not connected to the internet. There we go. The first tab here is really just an overview of how drugs become eligible, and for this year, how they did. There were 582 drugs that had a WAC per course of treatment of over $30,000 per year. Then there were 9 brand name drugs with over a 10% increase in the previous 12 months, and then 13 biosimilars that hit that list. So this is really just the bucket of how they fit into expenses, and then just the top 10 in the APCD claims to give an overview of really what we were seeing here. But then the meat of this dashboard is really in this this sheet here. We have an overview of the drugs that are eligible and how much they cost, and the 5 main selection criteria data points that the board prioritized, which are the number of patients utilizing the drug, how much the WAC has changed in the previous 5 years, what the patient out-of-pocket cost is, the total paid amount in the APCD claims, and the average paid per person per year. And then we just have essentially like the distribution of these drugs here. The distribution is hard to see because there are so many, but you are able to look at specific drugs and see, you know, this is the most utilized and also the highest cost, or the highest in total paid in those claims. Then folks are able to go through this list. You can sort it in any way. So if you're most interested in the out-of-pocket cost and which drugs had the highest out-of-pocket cost for commercial and Medicare Advantage patients in Colorado, you can sort the list by this and kind of see, you know, what are these most expensive and how do they fall across these points. And then the next sheet in this dashboard is really a tool that is for all of the 604 drugs and every single data element. So it allows you to look at one drug at a time and see all of these data elements for it. It is right now just alphabetical, but I can go to one of the drugs that the board actually selected, and I'll just go to the first one alphabetically, which is Cosentyx. And it shows us how many folks used this combination of the drug, the percent change in WAC over the previous 5 years, the average out-of-pocket cost for folks with commercial insurance and Medicare Advantage, the total paid in 2021, as well as the average paid per person per year. And then here are all of the other data elements. There are a couple that the PDAB gets through contracts we're not able to share publicly. So the board receives that information and it is helpful in their decision-making. It's just not here. And then, you know, different ways that we can break down the data and really look at it. This is really high level, and we learned in sharing this with the board that they have a million more questions about everything, and you know, so do we. But 604 drugs is way too many to do that kind of a deep dive on. So that's why it's kind of exciting to be in this affordability review and get to really dive down into the payer mix or the breakdown of where out-of-pocket costs come from and what kind of plans are folks on who are getting this drug, and all of the patient experience and what providers have to say. So it is really an interesting deep dive that will help the board make that next decision. But this dashboard is ultimately how they made that first decision. And I will say that this is the first year. This is the first attempt at this dashboard. And we do have a lot of plans to improve upon it next year. but I think it was pretty useful to get them to this point. So I think I'm done with this presentation if we want to move over to questions.
Thank you so much. Yeah, let me bring back, I'll just put up our information so everybody has it too while we're doing Q&A. And I see some things have come in the chat. Sarah, I appreciate your input on what I did not want to come out of my mouth was that specialty drugs are not important. And you're absolutely right. Sometimes that is the only treatment that there is for certain chronic conditions. And the problem is the cost, not that the drug is available. And we want to make sure that the drugs are still available. And I think that that's a part of what the PDAB is really going to be looking at next, because price is only one part of the equation. We really need to make sure that people are still getting access to these drugs and that it is affordable for people to access the drugs. So absolutely, sometimes the specialty drugs are the only thing that's available for certain chronic conditions, and we want to make sure that people still have access to those drugs. So I appreciate that. In terms of probably the PDAB folks, Kate and Lila might want to say a little bit more about that. But I'll jump to your next. Here's the definition. I'm putting it in the chat of specialty drugs. But there isn't a common definition, to your point, across payers. The drug rebate information that we get, the payers are telling us which drugs they're spending money on that they consider specialty drugs. It might be different from another payer because there isn't a complete list of like, these are specialty drugs. However, there are some tools in the way that we define it in the APCD claims is that we use the Magellan definition, which I believe Medicaid uses that too. So not all payers might be using the same definitions, but in general, the specialty drugs are defined as they're treating rare and complex diseases. They could require special handling or storage or administration or patient monitoring. Most notably, they are different from generics and brand because they typically are more expensive and often the only kind of drug that can treat certain conditions, which again, to your point, is really important for chronic disease management for certain rare types of chronic conditions and things that people deal with. So I don't know if Lila and Kate, if you want to talk anything more about like the next stages of like consumer input that you guys are going to be doing now that you have your list of drugs. I think that is important work that you guys are going to be focusing on to talk to consumers and make sure that the next phase incorporates that perspective.
Yeah, I can speak to that a little bit. So I think that it was, I think, very apparent to us that, at the stage where the board was selecting drugs, they had to do it objectively, right? And so they had to kind of look at the same information across all 604 drugs. But as Kate mentioned, now that they've selected them, really diving into the voice behind the numbers. And I appreciated Sarah that comment of like, it's not just the number, you need to understand more beyond that. And so there were a number of stakeholder meetings held. They concluded on October 12th, but so a number of stakeholder meetings held to hear from patients and caregivers, as well as individuals with scientific and medical training. The division put together a number of surveys, so 2 different surveys that patients could take to provide information on their experience with the 5 prescription drugs if they weren't able to attend a meeting. And then additionally, there is kind of a bucket of criteria where the board can consider any voluntarily submitted information from any entity. And for a number of these drugs, the board received a large amount of input from patients. And so it's been a little hard because the board hasn't met since the deadline, but it's something where when the board meets at their next meeting on October 27th, I would not speaking for them, but would not be surprised if a large portion of their discussion is focused on what they have heard from patients, both via the recordings, the surveys, and that voluntarily submitted information. And what does that, we've got numbers, we've got data, and then we also have this qualitative component of the patient experience and the provider expertise. And so I'm excited, I'm excited to see kind of how the board weighs all of that together.
We also have a question around certain types of drugs that have price increases, and that is part of, you know, what you guys are looking at, right? Like which drugs are increasing the fastest, and I don't know if you want to speak to that real quick.
Yeah, so in statute, it's a 10% increase in the previous 12 months for a brand name drug, and for a generic, it's a 200% increase. There was legislation in the last session that updated that, and I don't remember what the new threshold is. It goes into effect in January of 2025 and won't split out generic and brand name. And the previous 12 months is interesting because some of these drugs didn't qualify based off of that 10% increase. But when we look at them, some of them have over like 1,000% increase from their launch price, but it's been a slow increase, 5% each year or something like that. And so it is interesting to see that. And I'm curious to see if with what's been going on in the news lately, if the board might focus a little bit more on some of those drugs in their next round of selection.
And then there's also a question about, is there any evaluation of what the pharmaceutical industry spends on advertising drugs?
Not within our purview. We have a whole mess of data to gather and information to gather for the affordability reviews, and some of it gets into I'm trying to think of the permissive factors, Lila, just like other things, about like the prices of the market and other things going on in the industry. But as you mentioned earlier too, Carrie, even just the rebates it's not transparent. We have some rebate data, but it's not directly applied to how the individuals or even the carriers in Colorado experience a drug. So there's a lot that we're hoping to understand to really paint a full picture of a drug to the board. And that is potentially one of them, but I also don't know if that's, publicly available information that is easy for us to get.
Thank you. Any crystal ball as to how Medicare negotiations will play into the board's work down the road? It's a great question.
That's a great question. And this year, 2 of the drugs that the board picked, Medicare is negotiating. The affordability reviews and upper payment limits will be happening, this winter and spring kind of. And I don't think we will know Medicare's fair price until next September at the earliest. I think that is a fabulous benchmark to have if and when that becomes a public number. I'm not sure how that will interact with a UPL if the board chooses to set it on those 2 drugs. But I am hopeful that if in the future the board selects a drug that CMS already has published a maximum fair price for, that's a really excellent benchmark for the board to consider when setting a UPL.
Great. I don't see any other questions, but I do know we have some friends from the Indiana APCD. So thank you, David, for joining. He's been asking us questions. So we'd be happy to help you in terms of if you guys are going down the road of collecting any annual files like the drug rebates. We have all the information. So if you need any help on that, let us know. Happy to help. We have one more question that just came in. How is the upper payment limit enforced?
Yeah, I can speak to that. So if you look at the enacting statute, the upper payment limit enforcement authority is within the Attorney General's office. So that's kind of where it lies. But that being said, I mentioned the carrier use of savings report that's required. And so that's really for the board, their key kind of look into the effectiveness of the upper payment limit. So there is a rule on the board's website, as well as an Excel file template that was created for carriers to use when they're reporting how they used upper payment limit savings. And essentially at the most basic level, carriers would need to report annually the estimated savings from an upper payment limit. And there's information on changes in utilization, changes in paid amounts there. And that estimated savings needs to approximately equal the sum of reductions in out-of-pocket cost for prescription drugs for those patients and or reductions in premiums overall. And so we're I think the board and the division's excited with when the first upper payment limit is in effect. It's a retrospective look, so this reporting wouldn't come for a while, for a year and a couple of months, but really looking at how did carriers use upper payment limit savings to reduce out-of-pocket costs and premiums.
Wonderful. Thank you. I do not see, oh, maybe super helpful explanation. Thank you. I see no more questions in the chat at this time. So again, this recording, the slides, everything will be available on our website under About Civic, and then News and Events tab. We have an events page that we will post all of our information. You can see historic webinars as well on that same page. We'll post it to our YouTube channel as well. So we really appreciate both Kate and Lila, you guys joining us today. Love our partnership that we have with you guys. Love working with you guys at the DOI. Really appreciate the work that you guys are doing to make prescription drugs more affordable. I think it's so important that people still maintain access to drugs, and cost is such a driving factor to that. So appreciate all the work you're doing. If you guys ever need any of us, there's our information right there. We'd love to hear from you guys. And we look forward to seeing many of you on our next webinar. So we'll give you guys some time back, 15 minutes in your day. Have a good one, everybody. Thank you.